Hi, this is Elliot Fishman, and let's get started. So this will be part 3, and this will be the last part of small bowel tumors. As I mentioned, we did GIST, carcinoid, adenocarcinoma. Let's pick up with lymphoma, third most common small bowel malignancy. When you think about lymphoma in general in the GI tract, the stomach is the most common affected portion, followed by small bowel. Distal ileum is the most common area of involvement because it has the greatest amount of lymphoid tissue. Most cases involving small bowel are B-cell lymphomas. T-cell has a high association with celiac disease and occurs more commonly in jejunum. Risk factors for small bowel lymphoma include AIDS, IBD, immunosuppression after organ transplantation, lupus, chemotherapy, and Epstein-Barr virus, particularly with Burkitt's lymphoma. In Western countries, B-cell lymphoma of mucosa-associated lymphoid tissue or malt lymphoma is the most common subtype of primary small bowel lymphoma. T-cell lymphomas are much less common. And when we talk about them in terms of the CT appearance, it's variable. Infiltration, aneurysmal dilatation, nodular filling defects, endoexoenteric form with fistulae are kind of very, very classic. If you look at presentation, often the presentations will be variable. Here's an example of patient with small bowel obstruction. You're looking for the cause of small bowel obstruction, you're following it downward, and you see there's an infiltrating tumor by the ileocecal valve involving ileum and cecum. Could it be a cecal cancer coming backwards? Could it be a lymphoma? Could it be an adenocarcinoma of the terminal ileum? You very nicely see the differential enhancement and comparing it to the dilated fluid-filled small bowel. You particularly see it nicely on the coronal view. Look at the extension from ileum into cecum. Things that cross over, I guess occasionally a carcinoma can cross over, but you got to be thinking lymphoma. And this indeed was a small bowel lymphoma intussuscepting into the patient's right colon, very nicely shown on these examples. And again, just looking at the value of the coronal view, looking at the ability to define transitions, the soft tissue mass, and again with cinematic rendering, look how nicely you see the rendering of the fluid in the bowel. Then you see the increased soft tissue density, which is the cause of the mass, very nicely seen on the sequence of images. I mentioned B-cell lymphoma. I mentioned AIDS is one of the conditions, and we saw a lot of lymphoma when the AIDS epidemic was way up there. But here's a patient with chest pain, abdominal pain. We were looking for dissection. Look at this mass involving the left atrium and right atrium. That's a tumor. Could be an angiosarcoma, but could be lymphoma. And you're really sure it's lymphoma when you scan into the abdomen and you saw this large exoenteric mass involving the terminal ileum. A very nice example of lymphoma of the small bowel. You can see it here, the ulceration on the coronal view. Again, what this could be, it could be an adenocarcinoma, that's a possibility, but you give the chest with the abdomen, the cardiac involvement, you're talking about a lymphoma. Another example, in patients with HIV, the tumors are often very, very large. Look at the left upper quadrant. The whole thing is filled in by tumor, ulcerations, necrosis, infiltration, coronal view. Beautiful example of the large ulceration of the tumor. Full field of view images. Just extremely impressive how large, in fact, that tumor is. And that's a hallmark of lymphoma, though I have to admit, a GIST tumor, exophytic ulcerations would be a possibility. Lymphoma can involve the mesentery, and the sheet of tumor in the mesentery, the sandwich sign, is so classic. Coronal view beautifully showing you the SMA and SMV encased by this infiltrating tumor. And, carcinoid, we showed SMV, SMA involved, but with a desmoplastic reaction. This is a soft tissue mass that's infiltrating, shown nicely on the volume rendered views, showed nicely on the cinematic. You see the vessels going through what we used to call the sandwich sign. Just a beautiful visualization. And there it is down into the mesentery. Just extremely impressive detail as to the patient's tumor. Now, with lymphoma, particularly when it's multifocal and when the small polypoid type lesions are a little bit larger, they can intussuscept. Almost any tumor, benign or malignant, can intussuscept. When you see, as in this case, multiple sites of intussusception, you better be thinking about lymphoma versus metastatic disease. In adults, 70% of intussusceptions are due to neoplasm. Adult intussusception of the small bowel is usually benign tumors, large intestine usually malignant. And ileocecal valve, ileum into right colon, is typically going to be malignant. And just a list: benign causes, congenital, Meckel's, cystic fibrosis, tumors from Peutz-Jeghers to inflammatory polyp to lipoma to adenoCA lymphoma metastasis, and some of the functionals like Crohn's and celiac disease. I think it's important to remember that adenocarcinoma is the most common pathology of small bowel intussusceptions, but it doesn't need to be the only thing. Lymphoma, sarcomas, metastasis can all do it. I am seeing more metastasis these days, presenting with intussusception, acute abdomen in a patient, and voila, you see the intussusception. Here's a nice intussusception in the patient's right lower quadrant. In fact, there are several intussusceptions in a patient with metastatic melanoma, very nicely seen on this example. And again, you can see the telescoping of the mass with the fat being drawn with it, particularly well seen in this case on the coronal view. It's very much variable what shows it best. Often it's the freehand looking at the best image that makes it easy, but again, very nicely showing you the intussusception. Now, one question with small bowel tumors, we like CT. People would say, why don't you do endoscopy? Well, capsule endoscopy. 50,000 images, and initially it was like 100% accurate 100% of the time. But we know that capsule endoscopy has all sorts of problems. It's at best 50% accurate, takes a long time. If the patient has strictures or other disease, it can become obstructed. You can miss lesions due to improper bowel prep, rapid transit times, presence of blood, and capsule retention can take days. You can see a challenge. Okay, here was a patient, abdominal pain, and I told them they had a large mass. This patient had a prior Merkel cell tumor. This was obviously metastatic disease obstructing bowel. And I don't know if the message didn't get there or what, but someone gave it a capsule. And guess what? The mass obstructed the capsule. Many people recommend CT first, and if you see obstruction, you can't give a capsule. But here, you have a capsule. There's only way for the capsule to come out, and that's going to be by surgery. Just something you don't want to do. And here's a picture of the capsule, and there it is. Looks like a Sputnik if you look at the patient's topogram. Now, I went through the big four of primary tumors, but also you need to think about metastasis. And there have been many articles written. We wrote this article in 1998. I've seen nothing big since then. We're, in fact, putting something together now. When you look at Mets to small bowel, as patients live longer, the chance of Mets is increasing. Think melanoma, lung cancer, carcinoid, ovary or colon cancer. When you talk about Mets to small bowel, it could be from intraperitoneal seeding, hematogenous metastasis, or direct extension. And classics would be ovarian cancer for peritoneal seeding, hematogenous Mets, lung, or melanoma, direct extension, pancreas invading the duodenum perhaps. And just some examples. This patient has synovial sarcoma. Look at the liver Mets, ascites. Then look at the bowel. The bowel is obstructed, but you can see there's masses in the bowel because the patient has multiple intussusceptions, nicely shown on this set of images. And then you look at the views in coronal, and you see the patient has multiple enhancing nodules in the small bowel. And these nodules were the ones that were causing the intussusception. Here's a patient with a renal cell carcinoma. You see the bowel falling into the right renal fossa. There's a 1 centimeter enhancing nodule. Yes, it could be a carcinoid. Yes, it could be a neuroendocrine tumor. The right history, you kind of have to go with the money, and you're typically going to be right. This was proven to be metastatic renal cell carcinoma, very nicely shown in these examples. We talk about melanoma, multiple large ulcerating masses. Here's one example with a large mass in the right lower quadrant ulcerating. There's another mass on the left side. If this was lymphoma, exoendophytic lymphoma, sure. But when you start seeing multiple masses, we always think about melanoma, though it doesn't have to be melanoma. We think about metastasis in general. This was melanoma. Another example here with melanoma. Patient presents with jaundice and was sent for a pancreatic mass. And it looks like a big pancreatic mass, but there's no pancreatic duct dilated, and when you looked hard, it looks like the pancreas was pushed. What could do this? A large GIST tumor, maybe a carcinoid tumor, maybe some other malignancy. This was metastatic melanoma. And we've seen melanoma several times going toward the head of the pancreas with very large metastasis. And here's just a coronal view. And I mentioned we see it all the time. Here's another case I just saw. Look at the size of that mass invading the duodenum, very nicely shown. There's mottled attenuation, areas of hemorrhage are present. Here it is on the cinematic, beautiful example involving the SMV, the encasement and necrosis of the tumor. Very nice example. And if you look carefully, you can see things like bowel obstruction. So with patient's direct extension, here's a good example, carcinoma of the tail of the pancreas directly extending into the patient's duodenum. Beautifully shown there, or on the coronal views, or in the volume rendered views, or in the volume rendered and cinematic views. But you can see this bowel obstruction, there's a mass. The patient's pancreatic cancer's presentation was small bowel obstruction. An unusual presentation, but we've seen many cases of that. So I've now gone through with you primary and metastatic tumors. I've showed you some of the challenges in diagnosis. I've shown you many of the pearls. I've showed you many of the pitfalls. You see from the articles, we should be able to pick up nearly all tumors. Technique is everything. Post-processing is everything. And thinking about the possibility of a malignant small bowel tumor also is important. And hopefully with these 3 talks, we're able to make you think more about it. And we'll see you next time on CT is Us.